So we will be discussing about the clinical evaluation of self-expanding, indigenous self-expanding transcatheter heart valve by name Hydra, studied in Genesis 2 study. This study has been presented already in EuroPCR and is under under review for publication now. We all know about Hydra valve, indigenous valve produced by Sahara Medical Company. It's available in three sizes: 22, 26, and 30. The primary objective of Genesis 2 study is to assess the ongoing safety and performance of transcatheter Hydra valve in treating severe aortic stenosis patients who are symptomatic and who are deemed high risk for the surgery at the local heart team approach. In addition, we also like to compare the data between Genesis 2 and Genesis 1 historical outcomes if feasible. There are 19 centers included in this particular study. So let's brief about Hydra platform. It's a bovine pericardial tissue valve, supraannular design, large cells. Even it can accommodate even 15 French catheters through the largest part of the cell. As I told earlier, it comes in three sizes: 22, 26, and 30. It's got a differential tensile strength. The maximum tensile strength is at the level of the inflow and followed by middle portion, followed by outflow. The three tentacles which holds the valve to the delivery sheath. It has got a hydrophilic delivery system, so non-braided one. 14 French inline system is available for this particular study, which was not there in the Genesis 1 historical outcome. So this is the way that specifically this got this is the first valve which came out with an active release. It has got a knob here, following which the sheath releases the valve. Sometimes if the tentacles do not get released, we plug out this screw, following which we will be able to release the valve actively. So this is the active screw, safety knob, and this is the secondary knob with which we could relieve the, if you appreciate it, if the tentacles are not released, then the entire system goes inside in such a way that the tentacle get released. We will be able to see it fluoroscopically also. A short video regarding the same. Once the safety knob is released, then we will be rotating it counterclock. This pushes the delivery system towards the LV, and the tentacles that was held between the tentacles that are held in this particular groove get released automatically. It's not the tentacles that get released, the system that was holding the tentacles moves towards the LV, and that makes the tentacle release. In this particular study, it was done for over a period of 2 years, stringent inclusion criteria, so that is the reason it was slow, and it has got a learning curve to release the valve. So we screened 43 patients, we included 40 patients, 30-day follow-up is available for nearly 39 patients, 6 months follow-up is underway now. The inclusion criteria included severe symptomatic aortic stenosis who are deemed high risk for surgery with a minimum of STS score more than 3. Between more 3 and 8%, the heart team should declare that surgically it's a high risk candidates. Otherwise, those patients have not been included. Exclusion criteria include bicuspid aortic valves, patients who had a large aortic annulus or a very small aortic annulus not feasible with this particular anatomy, patient who had severe LV dysfunction or who has got severe TVD or poor lung capacity with an expected survival less than 24 months. All these patients were excluded from the study. The mean age was 74. Predominant patients were male, 65%. The average STS score was 3.5. Majority of none of the patients had a simultaneous PCA done. If the CAD was there, patient should have undergone PCI 6 months before to including in this particular study. If you look at the data, 100% was transfemoral and conscious sedation was used in all the 100%. The predominant valve used is 26 millimeter valve. Pre-dilatation was used in nearly all the patients, and post-dilatation was used in nearly 50% of individual. Average fluoroscopic time was 40 minutes. The contrast volume was a little bit higher because of self-expanding design, 200 ml. The hospital duration was 4 days plus minus 2. The primary safety endpoint was obtained at 30 days was obtained in 2.5%. The primary performance endpoint was again obtained in 95%. All cause mortality was seen in one of those patients. One patient had a device related mortality. Other patient had none of the patient had any stroke. The pacemaker requirement was also significantly lower to single digit number 7.5%. Unlike the other self-expanding design which flares out in the inflow, this is a tubular outcome. That is the proposed reason why we have got a lower pacemaker rate in this particular with this particular valve. As expected, there is a significant decrease in the gradient and significant increase in the aortic valve area from 0.6 to 1.9 over a period of 30 days, which remained the same. NOHA class as expected increased significantly and paravalvular leak, significant paravalvular leak not noted in any of these patients. Mild leak was noted only in 10% of individuals. 6-minute walk test as expected again increased from 200 to nearly 275. Device success as compared to WARC, when we compare the historical control, that is Genesis 1 study published in JACC Cardio Intervention a couple of years before with the Genesis 2 platform population, there was no significant difference what we saw except the 6-minute walk test, which was actually poorer in Genesis 1 patients. Genesis 1 patients were much more sicker patients as compared to Genesis 2 patients. That is the possible reason why these patients had a significantly lower 6-minute walk test as compared to the current patient population. Just to show a single case, a 85-year-old female, surgically deemed inoperable, severe aortic stenosis. The aortic annulus was perimeter was 20, perimeter diameter was 20, perimeter was 65. The coronary heights were quite pretty decent. We had a kind of significant calcium exactly at the common iliac aortoiliac bifurcation. Left was having a reasonably better lumen than the right. There is a calcified nodule there. We thought let's try with inline. This is the video that says how the inline of this particular system crosses. There was no resistance encountered in the particular zone where there was eccentric calcium, and the tensile strength of the valve is relatively less as compared to the other system. So, there was no, usually we do not encounter significant difficulty in negotiating the valve across the aortic arch. Valve is getting positioned. It has got two markers here. This is the first valve that comes with an implantation depth marker in the world. This marker is 5, 6, 7 respectively for 22, 26 to 30 millimeter valves. Cusp overlap was utilized in all those 40 patients. Rapid pacing protocol. This is node 3, this is node 4. Once it goes become above the node 4, till node 4 it is recapturable. The valve become functional once the sheath goes above the node 4. We stop there. So, this is the video that says that the valve got released. 2 tentacles have been released, however, one of those tentacles has not been released in this particular case. So, we release the safety knob and get the system slightly inside with this particular rotation of the secondary knob. With this, the valve got released. That is it, access has been closed. So, to conclude, Hydra transcatheter valve is the first device that came with the implantation depth marker almost 6 years before, and with an active release mechanism deploying the supraannular valve. Good rate of success and procedural safety was observed in Genesis 2 study, which is comparable to Genesis 1 study. With a lower pacemaker rate, with a better bovine pericardial design as compared to other self-expanding platform, with a better lumen annular, with a better EOA obtained as compared to balloon expandable valves. We are extending the 6 months follow-up of this particular study. The study is under consideration for publication at this point of time.